you for joining us. I can see we've still got some people joining, but we like for it to be prompt, so we're going to kick off as it's now 3 o'clock. First of all, I'd like to introduce you all to Jacquie Batchford, who's been kind enough to give up some of her time today to talk to us about her experience of implementing change or rapid change in this time of the crisis that we've been having. Jacquie, thank you for joining us today. Jacquie, could you just give yourself a brief introduction so that everyone can get to know you a bit?
Yes, thank you, Susanna. Firstly, can I just say I'm not working in a cupboard. This is just a working office where I can have some quiet space, so my apologies for that. But anyway, I'm Jacquie. I've been a nurse for 34 years and I still am a registered nurse. But my other role is Director of Education and Innovation at Thames Hospice in Windsor, and I've worked it for an independent charity hospice now for 20 years. Thank you.
So, Jacquie, can you give us some sense of the normal priorities that you work with in your daily life in Thames Hospice?
Yes, I think if I just could tell you a little bit about the hospice, that might help get a feel for what I'm talking about. So we obviously care for patients, palliative care patients, so that are receiving non-curative treatment now. So either for symptom control, end-of-life care or respite care. So those are the three main work streams we have. And we deliver that via a range of services. So we have a 17-bedded inpatient unit. We have a community team, which before this situation arose, we had in two halves. One that did some proactive case management, and then a 24-hour rapid response team. And we also had day therapies, so where patients can come in for a day, get all the treatments they need, or they can just come in for individual treatments and outpatient appointments. That's how we run. And our primary focus at a hospice, for those, I don't know if anyone's had any experience of a hospice, is all around the patient, but also the family. Absolutely vital that we look after them together. And that is more so than one would see in the NHS, purely because that's our primary focus. We're then, the three ways we think about things are patient and families first, then our staff and volunteers. We have over 500 volunteers, and then organisational safety, which is around compliance with law and regulations and professional guidelines. That's us.
Okay, thank you. And given the advent of COVID-19, when did you first start to see the need to make some changes to your normal ways of working?
So we picked this up in January, probably like most people with the horizon scanning that we all do. We started to see it then, and certainly going into February, it's becoming, okay, this is becoming a little bit bigger. So we were starting to look then at what does that look like if any of our patients develop COVID. So I would say we started to change a few things then. We started to look at how would we work, what if staff, so staff processes, if someone got ill, how would you manage them, how would you manage a patient, how would we keep the patient safe? But it was in March when things significantly changed for us.
Okay, and so March comes, everything changes. So what are your key challenges? What were you looking at?
So key challenges are, we at that point think we have an NHS that is going to be overwhelmed, and that we are going to get a large influx of patients with COVID and without COVID. So how do we manage those two cohorts of patients in the same environment and also in their homes? We also have a large, so that was our priority. And how do you manage visiting around COVID for family members that we're also trying to keep safe? Then we have our staff and volunteers. Now, a lot of our volunteers, anyone who works with volunteers, and I won't say all, but we have a lot who would be in the vulnerable groups at over 70 who are helping us out with retirement, in their retirement. So it's about how would we manage our services with volunteers, how do we keep those safe? And as we moved through March, it was then how do we keep ourselves organisationally safe with changing guidance on a daily basis. So those were the challenges really for us initially.
Okay. So can you tell us how you went about making the decisions on what you needed to do?
So very quickly, we, as a senior management team, decided to meet daily.
Mm-hmm.
Luckily, we had a big enough room that we could all socially distance, or people were invited in via Zoom so that we could have those. So daily meetings at 4 o'clock. 4 o'clock was chosen so that we could respond to any guidance that was sent out that day. Mm. So we were each, so I'm a nurse by background, we also have a director of nursing, so our responsibility was checking the clinical guidance. We have an HR director who was looking at the employment status. We would bring that together then, so everyone would bring that together at 4 o'clock. And that was really important. We came informed to that meeting, because at that meeting we would then make a decision, and it had to be a decision in that moment then that was safe, that we got consensus, because after that out went the communication to staff. And also we have a board of trustees because we are a charity. There was a call afterwards with our CEO to the board chair around our decision making and where we were. So very engaged, really sort of golden thread, if I could put it that way, really down from our patient right through to our chair of trustees. Mm.
So tell us what changes you made in terms of how you were working and also how you were leading as a leadership team.
So I would say we've got about 260 staff. So a medium-sized charity. We also have a large retail component, so we have people working off-site in shops. So that's how we're used to working like that. But we do have to remember we have the retail staff as well. So the first things we go, because of our focus, is patients and families safe first. So we did immediately, we cohorted our patients. Lucky enough, we have a physical space where we could have a cold wing, where patients with non-COVID were cared for, and a hot wing where COVID patients, either who were admitted with COVID or developed COVID with us, were able to be cared for. Everyone has heard about PPE. There was a mass then of trying to get us PPE. And we were having to make decisions daily based on how much PPE we had. So what I mean about that is, do we have to ask family members to sit 2 meters away from their loved one because we don't have enough PPE to give to families at the moment? I have to say that was corrected within about 4 days, and we've had PPE all the way through. So, but it was donning and doffing. Everyone's probably heard about donning and doffing. We had to teach this. So we had to teach that. So that was my responsibility, was to teach the staff doing that. Lots of small group work now, because obviously we can't have large groups of staff together. They're very small group work. So it's something that you wouldn't normally do. It's not normally cost effective, but that sort of went out the window at this point. This was about safety for our staff, but being alongside them as well. Mm. And I think that was the other big thing we did as a senior exec team. We have 3 nurses. So the chief executive, director of nursing, and myself are both registered nurses. And we were on the floor with our staff. So I'm lucky enough, I don't mind working night shifts. So I was doing 3 nights a week at that point, as a proper staff nurse alongside the team, role modelling how to use the PPE, answering any questions that they came up with. And the chief executive and director of nursing were working on the day shift to support. So that was, we do that occasionally, but we did that a lot in those first few weeks. Mm.
And how did you get all the communications out to your staff about all the changes you were making to the processes that you were using?
Yes, because we are also, because of keeping us organisationally safe, we're also changing our policies at the same time. So a lot of our clinical policies had red COVID information added to them, and that was allocated to a specific clinician to get those written and out. Now, we're a hospice and we love face-to-face communication. So all of this went out by email. But of course, we have our nurses, our healthcare assistants working with patients for their 8-hour shift. So they don't actually read their emails. So again, it was that alongside working, we had hard copies out in clinical areas. We put lots of posters up to where we could simplify information to get the core bits, the really important bits that they needed to do, laminated so that they could be cleaned, posters around in the relevant areas. But a lot of it was we worked alongside them.
And how did your staff feel going through this massive change of not only the living at home and at work with the challenges that they were facing, and also the changes you're making to the processes that they have to operate?
I have to say, the staff, and I think they would say this themselves, they were scared, wanted to do their job, wanted to be here, wanted to care for our patients and families. They were scared that they didn't know what they were doing initially. So this was on the, sort of that first few days when people are coming onto shift, scared for their families. And I think that was the overwhelming thing, but they wanted to be here. And again, if I'm totally honest, I think that took us 3 weeks to totally settle that down.
Okay.
So I don't think, I couldn't say to you that we did it in 2 days.
No.
Partly because we had people coming back off sick. So we have had some staff who were already diagnosed with COVID. So coming off sick or annual leave or days off. So you have that sort of, then you have to, you know, wait for them, be ready for them to come back, because then you've got staff that are in different places. Some staff that are quite comfortable and some staff that aren't, and they can cross-infect each other with that anxiety. So we have to be very mindful of that as well.
And so talk to me a little bit about what you did in order, so you're mindful of this. So how did you help settle that over that 3-week period with the staff in terms of them feeling confident and not scared?
So in our clinical teams, we basically, so we have what's called a handover at the beginning of every shift, be that in the inpatient unit or the community team. The sisters or the nurse in charge would then do a recap of where we were, find out if anyone had or hadn't been doing the donning and doffing. Education then were asked to come in and support that person. We proactively, when people were coming back off annual leave, they actually got a phone call to say we're okay. And we also set up a WhatsApp group so that staff could ask questions, excuse me, could ask questions. And what was very interesting, the team started to really pull together, going, actually, look, it's fine. You'd see other staff saying, no, honestly, I've been at work for 2 weeks, we're okay. Come back, we feel safer here than we do in Tesco's. And those were things that I started to see coming through, which was really great.
Well, I can imagine the handover between shifts was a vital part to play.
And we kept someone senior in there, every handover. So we have a handover in the morning, at lunchtime, and onto the night shift. And I'd say for those first 3 weeks, I did night shifts over the weekends, because that's where things can be a little tricky when you haven't got your senior management team around, or as many managers. What the staff didn't want was me turning up in a uniform and just wandering around. I don't think that would have been helpful. I think the fact that I worked as a nurse on the shift with them and alongside them, and as I say, the CEO and the director of nursing did the same during the day. That was really how we held that. So we front loaded this with lots of senior staff.
And you talked a bit about the sort of donning and doffing process of getting PPE on and off and so on. When we talked before, you mentioned the process of having to implement runners, I think, which is new for you. So
we have a corridor of side rooms, single rooms for patients. So it's putting on, it doesn't sound like much, putting on an apron, gloves, and a mask, getting into a room. If you've then got to take those all off in the correct way and wash your hands, go and get something, put it all back on again, that patient's care is going to take a long time. So we actually implemented a healthcare assistant runner who would be in the corridor, so that we would ring, so I was in it, so we did this on nights as well. Actually did have to increase our staffing a little to do this. I would ring the bell if maybe I needed a towel or a pad or something, ring the bell, because you can't keep anything in the rooms either, because then they're infected with COVID and you can't use them. So the runner would go and get us something and bring it to the door, and we would take it from outside the door. They'd leave it on the floor, we'd pick it up and do. So, and that was a really effective way to work.
Okay, yeah, I can imagine. So you talked a bit about the changes that you've made, but in terms of when you think about the future, so the impact that those changes have had, what do you think you've learned from that?
It's really interesting, actually. And I think we'll probably come on to later of what we're going to keep going with, but So 3 weeks, we had solid change embedded. So certainly in the inpatient unit, that was done. Now, we all know that change can take a lot longer than that to embed. And it certainly does here. I don't think we're abnormal in that. But for me, what we had was, we had a real need, and that need was very clearly articulated. It was very clear because of the situation we were in. So there was a real sense of urgency around that. So those are two things that I'm really interested in, and I'm picking a little bit more when we come through this. That if I were to replicate that, it's articulating that need in a way that everyone gets it very, very quickly, and then creating the urgency around the change. Because we were given those because of the situation we were in. So that really helped us. We made some, can I just talk about the community team a little bit here? Because we made some significant changes to the ways they work. So inpatient unit, fairly settled within 3 weeks. Community took a little bit longer, only because we significantly changed the way they worked. Because what we had patients at home who were scared and vulnerable, not only vulnerable because of their disease, but then vulnerable more so to COVID. So we needed to reduce that footfall into a patient's home. So we put that team into one way of working. And that took us about 2 weeks to get the processes right for that, because also we had to do some training for staff so that they all started to work in the same way. So we have one nurse now that will go in and do the proactive conversations and the discussions, but also can do all the symptom control. We changed their working patterns. And some were working 7-hour shifts, some were working 12. They all work 12-hour shifts now. And that was all done within 4 weeks. And that's a change we've had really, really positive feedback from families, but also from the staff, about being able to go in and do everything. So there's some efficiencies here.
Right.
We don't want to do cost savings from this, but could we see more people if we carry on working like this?
So the more that you do that, are you presumably you're analysing the kind of the data that you're getting from that response group for both the patient, families, and staff, and saying, so what works well, what could we improve, what could we do differently?
Absolutely. I think for any change, what you should be doing, and we are still doing that even in this rapid change in a very complex situation, is we change the KPIs to match how we're working. We're still doing the surveys, we're still doing patient satisfaction, we're still doing staff meetings, albeit by Zoom. We're still doing training by Zoom to our staff. So all of those things have happened. We haven't stopped doing things that you should do through change to see if your change is effective. We're just doing them a lot quicker.
Yes. And I mean, clearly the speed has been a necessity in the environment that we've been in. But what do you think you can take forward from the lessons of both the psychology of all the people that you're dealing with, you know, thinking about how you make change in the future as effectively as you have done recently? Because I think from, you know, our conversations, you and earlier in this conversation today, you said change would normally have taken a lot longer. Now, you didn't have a lot of choice. You had to be faster. But presumably there's some appetite to say, well, couldn't we, you know, how could we speed things up?
Oh, there's lots of things we want to take forward. And because we want to do that now, because we've seen different ways of working, is how do we do that? And I think the biggest thing we've taken away is, because we were in a crisis, that focus on what is your actual issue, what is your actual change, being very clear and very specific and very targeted over what that change was. And I think as a hospice, we're very face-to-face. We can be a little bit fluffy and collaborative, and which I think are all great things to be. But certainly for us as a hospice, we do that a lot, of getting buy-in over months. And I think we've seen that we don't need to do that. We've had our eyes open to our teams that they can do this because we were really clear and really targeted with what the change was and why.
Yes.
So that is what we have taken from this. If we can do this quicker in the future, we've learnt some really good lessons.
So as a leadership team, you're kind of taking forward that if we can be this focused in the future and communicate well, then the staff will buy into it. We don't need to coddle them, as it were.
Yes, absolutely. I think, and I don't think we've ever patronised our staff. I don't think that. But I think we can worry too much that we're taking them with us.
Yeah.
I think, and they step right up there into this space that we ask them to. And you have a little bit of a wow moment about your staff in crisis, I think, when you can see the best in people.
Yes.
So you can see the best in their emotional response to this, but you can also see the best in what they can actually assimilate very, very quickly and how they can adapt. And that's been a little bit of an eye-opener and lovely to see.
And so just talk to me about, so in the course of making these changes, in the course of communicating, what forums did you have for your staff, patient and families to communicate back to you?
Patients, that's been interesting. So we have tried some Zoom, Skype calls. Some patients and families have responded well to that. Most have preferred telephone contact. That's something they're more familiar with. And probably when you're feeling quite vulnerable, they haven't taken quite so much to the technology side of that. So a lot more phone calls. So for example, our patients that can't come into day therapies, they are getting weekly calls as a minimum, and it might be more than that to make sure we're picking up with then back up from our community team if we're worried about someone. The staff, we have revolutionised ourselves. We were very, very face-to-face. I think a lot of healthcare organisations are the same. We like face-to-face, we like touchy-feely, we like being together. And we have used this sort of technology now. So again, if I use our community team, we have weekly meetings via Zoom where we do a check-in. How are you? We do what we call a breathe session, which is where they can bring, they don't need to bring clinical things, they can bring how they are feeling, are they struggling, and we can do that as a group. So we're still together as a group, but using technology. So we're using what we have available to us, but where needed, we will still do small group work, but in a big space.
But you're asking the questions of, that's quite interesting, is that you're focusing obviously on the clinical elements of it, but also on the socio-emotional.
Yes, absolutely. I think I may have mentioned this before to you, Susanna, but we call it vicarious trauma.
Okay.
So where our staff are watching other people death and dying and distress, which they do. So we put a lot of psychological support in for our staff. It is not normal to see that much in your lifetime, and they see it every day, and that's increased. So therefore, we increase proportionately the support that they get, but we deliver it in a different way.
Okay. So any kind of final last lessons for the future that you think will be sitting with you as you move on through and out, and people talk about the new normal? What will the new normal look like for you, do you think?
That is a massive question, actually, in the sense of what is the new normal?
Yes.
Because I think COVID is going to be with us for a long time. And I think every organisation, we have to adapt, because this is not going away. Certainly this time next year, if we've got a vaccine, maybe we'll be able to get back to normal. But certainly today we are looking at, certainly as a hospice, that we are preparing for the long term, that there's these changes. So we talked about how we do change. So we've learned from that. We're still going to evaluate in how we move on. We're looking at the moment of definitely this use of technology for us, about remote working from home, so that people can work from home. I am Director of Education. I have next week 2 fully booked weeks of teaching via Zoom to care homes, because we're also supporting our care homes. I've just looked at my stats, my planning document. The amount of care homes I can do in that time is amazing.
Mm.
Doesn't take away the need to do face-to-face for certain things, but this may suit us. So we're definitely looking at, will we keep that going? Well, I will be keeping that going within my role. I think as well, I suppose once we come out of COVID, can I just say this? I think looking at globally, one's working from home has to be something that we look at, because I think not only for the individual, but actually to save our planet from everyone in their cars and trains.
Yeah.
So we're not only looking at what does COVID look like, but what does it look afterwards. We think this has transformed and changed us probably fundamentally forever, but we just don't quite know how yet.
Yeah. Okay. Thank you, Jackie. To those who are on the webinar, there is a chat window at the bottom of your screen. If you have any questions that you would like to ask, then if you click the if you click the Q&A, then I will be able to see in there any questions that you've got that you'd like to ask Jackie. So please, if you've got any questions, now would be a good time to post them. Just hang on a moment, Jackie, while we just finish this. Okay, well, I can't see any questions coming in, so I think that you've hopefully addressed what everybody was hoping to understand from today. Thank you for your time, Jackie. I appreciate you're in a job where we need you to be doing your job rather than talking to us. So I really appreciate the time that you've taken today, and good luck for the future. For those of you that are, as I say, on this, I'm just going to share a screen with you now, which is the how to get in touch with Thames Hospice if you are interested in knowing more information about Thames Hospice. So it's got their website, Instagram, Facebook, and if you would like to donate, if you've been inspired by the work that Jackie and her colleagues are doing, then please feel free to donate. Jackie, thank you very much for spending your time with us today, and I look forward to speaking to you in the future.
Thank you very much. Thanks, Susanna.
Thanks.